Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM from Houston, Texas. In this presentation, we're going to talk about Hypertension Treatment Review 2022. Here's a reference to an article which I am going to be quoting. The definition of hypertension is when the blood pressure is greater than 130 by 80 millimeters of mercury. 116 million adults in the United States have high blood pressure. That's almost 1 in 3 out of the US population has some degree of hypertension in their lifetime. Here are some of the main reasons why we should be concerned about high blood pressure. You can follow my arrow here. Its effect on cardiovascular system, including heart attacks, heart failure, visual problems, and of course, the major complication is stroke. One thing that's not mentioned here is chronic kidney disease, and hypertension has been called a silent killer. A systolic blood pressure reduction of just 10 millimeters of mercury reduces the risk of cardiovascular events by 20 to 30%. So that in itself, along with stroke reduction in the long-term basis, should be a compelling factor in treatment of this silent disease, which is hypertension. There is a multi-pronged approach to the management of patients with hypertension, starting with our diet. Reducing calorie intake, reducing fat and cholesterol intake, and reducing our salt intake will have a profound effect not only on our overall general health, but also in reducing the blood pressure and potentiating some of the medications that we use for treating moderate to severe hypertension. A weight control of 10 kg reduces the systolic blood pressure by 10 millimeters of mercury. So if you take into account here from the previous slide which I showed, that 10 millimeters of mercury, reduction in 10 millimeters of mercury decreases the risk of cardiovascular diseases by 20 to 30%, and by the same token, if we can drop your weight by 10 kgs, you can reduce your high blood pressure and also, namely, the cardiovascular complications. Controlling diabetes definitely will help to get your blood pressure under control. Exercise, any combination of these sort of potentiate the effect of the overall medical treatment. Let's talk about salt. Salt has been considered a significant factor in hypertension. The higher the salt intake, the higher is the blood pressure. The salt that is in the arterial walls increases the stiffness, which leads to increase in vascular resistance that leads to hypertension. A salt reduction or a diuretic, which helps to get rid of the salt, helps to bring the blood pressure down. How much blood pressure reduction can we expect with a diuretic? And here is maybe 5 millimeters of mercury reduction with salt reduction. But when we are talking about salt, we have to understand the salt not only is the extra salt that we put in the food, but also the salt that is already in the food products, especially canned foods, which are high in sodium. Certainly, we can use salt substitutes to reduce the amount of sodium intake, which will help to bring down our blood pressure. We have 4 main classes of drugs available for treatment of hypertension, namely the diuretics, ACE inhibitors or ARBs, which belong to the same renin-angiotensin inhibitor class. Then we have the calcium channel blockers. And finally, we have the alpha blockers, vasodilators, and other modalities. Before we look into this, let's talk about exercise. Exercise has numerous benefits, most of which you're familiar with: increasing fitness, increasing coronary collateral circulation, giving you a sense of well-being, helping you to reduce weight. You have to exercise for 40 to 60 minutes, 3 times a week, in order to see a substantial reduction in the blood pressure. But with exercise, you lose weight, you improve your carbohydrate metabolism, and when you're exercising, you're eating better, and hopefully all this combination of factors will help you to bring your blood pressure down in the long run. Let's talk about alcohol. In moderation, 1 to 2 drinks may be beneficial, may have a beneficial effect on hypertension. But I would be more careful about the effects of alcohol on the liver, and hence it is not essential that you need to have 2 drinks every day. Occasional drink would be fine. Potassium supplements have been shown to reduce the blood pressure by about 5 millimeters systolic and 3 millimeters diastolic blood pressure. This is with the Mediterranean diet. If you just take fruits and vegetables, the reduction is very modest, namely 2.7 millimeters over 1.9 millimeters of mercury. Nonetheless, fruits and vegetables provide a lot of nutrients, minerals, vitamins, and it's a good idea to have a potassium supplement in the form of like a banana. But remember, each banana has 100 calories. So if you have diabetes, that's another thing that you have to keep in mind. Fruits and vegetables or potassium supplements work better in patients with much higher blood pressure levels and in the African American population. Potassium salt intake in the place of sodium intake may also give additional benefit in that it has been shown to reduce the risk of stroke. One thing we need to keep in mind is hyperkalemia in patients with pre-existing renal condition. The Mediterranean diet, which was studied in the DASH study, showed 5.5 millimeters over 3.0 millimeters of reduction in the blood pressure in patients who were following Mediterranean diet. The study, which was reported in JAMA network, included 18 randomized trials, 15 meta-analyses, 6 longitudinal studies, 6 cross-sectional studies, and 4 scientific statements. So we're going to cover some of the highlights from these studies with particular reference to a clinician dealing with patients in the office or in a hospital. According to the 2017 ACC-AHA guidelines, the blood pressure is supposed to be normal if the systolic blood pressure is less than 120 and the diastolic blood pressure less than 80. Elevated blood pressure is defined as a systolic blood pressure of 120 to 129 over less than 80 millimeters of mercury. Stage 1 hypertension is 130 to 139 systolic, diastolic 80 to 89, and stage 2 hypertension is where the systolic blood pressure is greater than 140 and the diastolic blood pressure greater than 90 millimeters of mercury. When we are talking about hypertension, we should also calculate the overall cardiovascular risk by visiting the ACC-AHA website, which has a calculator. You can just Google this cardiovascular risk calculation and you can plug in your numbers, your age, your blood pressure, systolic and diastolic, cholesterol level, and history of diabetes and other issues, obesity. You can calculate your 10-year cardiovascular risk. Here are some of the important clinical observations which I would like to share. When we are choosing a drug, it is better to choose a generic drug when it is available and suitable in place of brand names, simply because they are the most economical drugs and they are particularly better for people on a fixed income like the senior citizens. These are drugs which have been proven to be effective because most of the new drugs were actually tested against these currently generic drugs. For example, enalapril. Most of the other drugs have been compared to enalapril to see how effective they are. So choosing a generic drug will greatly help in compliance, reduce costs, and equal benefits. Remember, it's a lifelong treatment. I personally look at 1 or 2 drugs in each class, like a diuretic, ACE inhibitor or an A or B and learn them thoroughly well. The starting dose, the maximum dose, the frequency, and the associated side effects on the heart, kidney, and metabolism. So, by knowing all these things, we can minimize the side effects of the drugs and also adverse effects of the drugs in terms of significant hypotension or other problems or worsening kidney function. We start always with a minimum dose, and we should be cognizant of polypharmacy problems. This is particularly true in older patients who are on 10 to 15 medications, and each one of these medications can have an additive effect on the other, with the overall result being side effects from the medications which were supposed to help the patient. We need to learn about the side effects and its effects when they are used in combination. When we are treating patients with hypertension, in the early stages, it may be just mild hypertension where it can be controlled with a diuretic, a beta blocker, or a calcium channel blocker. But as the age increases, as the disease progresses, as people develop more problems like cardiovascular problems, diabetes, or a kidney problem, those things will have a significant effect on the choice of drugs that we use and the dosages that we use. So let's keep in mind the presence of especially heart disease and kidney problems. And of course, all these patients need follow-up lab studies like electrolytes, heart rate, EKG, kidney function, so that we keep track of any side effects. And here are some of the studies showing the benefits or lack of benefits in treating patients with hypertension. And here's a SPRINT, which was a double-blind randomized control study, had 9,361 patients. Their baseline blood pressure was 140 over 78 millimeters of mercury, and the target was 120, so they almost dropped systolic blood pressure by 20 millimeters of mercury, and there was a significant reduction, 25% reduction in mortality. Clear indication. Here's a study STEP, which was reported in 2021, which had 9,624 patients. Their the baseline blood pressure was 146 over 82, and they looked at cardiovascular composite endpoints. There was a 20% reduction in the cardiovascular endpoints. There's a 26% benefit in the primary outcome for intensive pharmacological treatment group. This is where these patients were strictly followed with the guideline-directed therapy. Then here's a study by Neil in 2021, which included almost 21,000 patients. They looked at the incidence of stroke. The blood pressure was 154 over 89 millimeters, and they achieved only like a 3 millimeter drop after 5 years, but still the incidence of stroke was 29.14 versus 33.65 for 1,000 patient years. So this definite indication that controlling blood pressure would decrease the incidence of strokes. Here's a study looked at ACCORD 2010, 4,700 patients. The blood pressure baseline was 139 over 76. They achieved a target blood pressure of 120 over 64. And this was adult patients with diabetes with high cardiovascular risk. However, at the end of treatment, they did not find significant difference in lowering the blood pressure as it has been seen in other studies. And here is finally one more study looking at 3,000 patients, which showed a reduction in the incidence of recurrent strokes in patients who are on treatment for hypertension, and they were able to decrease the blood pressure from 143 systolic to 127 millimeters of mercury. Now we're going to look at various classes of drugs, paying particular attention to what's available, what are their dosages, and most importantly, what are their side effects and what are their cardiovascular benefits. Of course, we have the first line of drugs, namely the thiazides, and the most commonly used one is hydrochlorothiazide. Chlorthalidone in a dose of 12.5 to 25 milligrams given once daily has been shown to reduce cardiovascular mortality, whereas hydrochlorothiazide and the other diuretics have not shown a significant reduction in cardiovascular mortality. And of course, we need to be familiar with all these items, which I'm not going to read each one of them: hyponatremia, hypokalemia, hypercalcemia, hyperuricemia, and lipid abnormalities. You're all familiar with that. And the reduction in the blood pressure with diuretics was approximately 12 millimeters of mercury. Now we go into the ACE inhibitors. We have the ACE inhibitors. There are a number of drugs listed here. When I worked for the VA hospital, lisinopril was like a standard drug that was used in many patients. So I became very familiar with the dosages, frequency, and the side effects. So it's important to remember these things. And of course, we still have enalapril, which does from my point of view, does an equally good job. Know the minimum dose, the maximum dose, the frequency, and their side effects. We are familiar with the side effects, namely hyperkalemia in patients with the kidney failure and anaphylactic reaction, which is extremely rare. ARBs, I would stick to drugs that are generic, because these patients have to take these medications lifelong. The generic medications are, of course, losartan is generic, olmesartan is generic. Pick 2 drugs in each class and know them thoroughly well in terms of their starting dose, maximum dose, frequency, and side effects, and especially when they are combined with other medications. When you are using ARBs, we have the same side effects as those we see with ACE inhibitors, namely hyperkalemia in patients with the kidney disease, increase in creatinine level in patients with borderline kidney function. That's an important thing we need to keep in mind. So before we start these patients on an ACE inhibitor or an ARB, we need to know their kidney function, the creatinine level, and the GFR, so that we are cognizant of what their baselines numbers are, so we can follow them with lab tests after the treatment is started. Let's move on to calcium channel blockers. We have the 2 main categories, namely the dihydropyridines, in which group we have the amlodipine, which is a very popular, common one used, along with the felodipine and nifedipine. Of course, nifedipine causes reflex tachycardia. Nifedipine should be avoided in patients with ischemic heart disease, especially they have ongoing ischemia. Know the minimum doses and the maximum doses, and of course, some of the problems we see in patients with taking calcium channel blockers, especially dihydropyridines, may include peripheral edema and also tachycardia. Amlodipine doesn't cause that much tachycardia compared to nifedipine. And of course, a short-acting nifedipine has much more effect on the heart rate compared to a longer-acting nifedipine. Then we have the non-dihydropyridine calcium channel blockers, namely diltiazem, verapamil, and here are the dosages. The main thing we need to be concerned about with these drugs, namely diltiazem or verapamil, or bradycardia, increased conduction disturbances along with constipation. We need to make sure that we avoid these drugs in patients with heart failure with reduced ejection fraction or conduction disturbances. And finally, we have the MRAs, eplerenone and spironolactone. They both have been shown to have beneficial effects, especially in patients with combined heart failure. At the same time, we need to be cognizant of hyperkalemia, and we should be very careful about using potassium supplements in these patients. The beta blockers, metoprolol, carvedilol, and nebivolol. And here are the dosages. The main thing we need to be concerned about is their use in patients with asthma, and of bradycardia is a major problem, and conduction disturbances, and should be avoided in patients with second degree or higher degree of heart block. They are also beneficial in patients with heart failure. Potassium sparing diuretics, namely amiloride and triamterene, can be useful, but we need to be careful about their hyperkalemic effects. Loop diuretics are preferred choice in patients with reduced renal function and in patients with heart failure, and we need to learn the dosages of these medications because they are very frequently used in patients who have a combination of hypertension and heart failure or volume overload. Furosemide and torsemide are very familiar names. Know their dosages and know their side effects. We have the alpha agonists like doxorubicin, which can be given 1 to 16 milligrams once daily. It is a alpha adrenergic receptor blocker. It doesn't have significant effect on the conduction system compared to beta blockers. One of the things we need to be concerned about with these alpha blockers is orthostatic hypotension, especially in the older adults. Then we have clonidine, which is a centrally acting alpha agonist, which is used in very small, tiny doses like 0.1 milligram to 0.8 milligrams. But this is something which has to be given twice or 3 times a day, and it also causes a significant bradycardia and orthostatic hypotension. We have the direct vasodilators like hydralazine, minoxidil. When we are using direct vasodilators, we have to be careful because they have to be given every 8 hours, which can be a challenging task in patients who have to take it lifelong. Along with that, hydralazine also causes tachycardia, and that's one of the reasons it should be avoided in patients with ischemic heart disease, especially if they have ongoing myocardial ischemia. Hydralazine, in addition, also causes reflex tachycardia and fluid retention. Minoxidil is associated with hirsutism in women. So, ladies and gentlemen, this is a quick review of medications available for treatment and the initial steps we need to take in managing patients with various degrees of hypertension. Hopefully, this has been educational to you. I would suggest you look at that article and look at the references and use this as a guide. This JAMA article just came out 2 days ago, and today is November 15, 2022. I am Dr. NIK NIKAM from Triple N Media. Thank you so much, and please do subscribe to our YouTube channel, and I will see you in the next presentation. We have numerous presentations on heart disease and cardiovascular diseases, along with all the latest ACC AHA guidelines. Please do watch them, and please do subscribe to our YouTube channel. I will see you in the next presentation.